Good morning everyone, and good morning our dear second day of the Health Data Forum Global Hybrid Summit, now in a truly hybrid format. We apologize, day one we couldn't be with you. Today we are able to do so, and it's a pleasure for me to be here. I'm Paul Nunes-Dia, the fire starter of Health Data Forum, and it's with great pleasure that I'm now introducing the opening speaker for today, Professor Rhidian, Hurle and Matt Indle. They are going to, both of them I suppose, are going to introduce us a little bit on a recap of last day and setting the background for today's session, where we're going to have a keynote speaker, Dr. Emma Gordon, who is already here, and Tiago Taveira-Gomes, which unfortunately cannot join us in person. He was here yesterday, but he will be online delivering his keynote. So enjoy the day.
Morning everyone in the room and online. My name is Rhidian Hurle. I'm the Medical Director at Digital Healthcare Wales. It's a pleasure to be here on a sunny day in Cardiff. The Four Nations Plus group, digital leaders across NHS Scotland, Wales, England, Northern Ireland, and indeed the Republic of Ireland met yesterday. And so I wasn't here, unfortunately, in the afternoon to see the event, but my colleague Matt was, and I've given him the task of summing up yesterday.
Thank you, Rhidian. Morning all, and it's a real pleasure to be here at this Health Data Summit, which truly has global reach. Welcome to everyone online. Bore daw pawb is what we say in Welsh. So my job is to sum up the day yesterday, which I thought was absolutely fantastic. We had some wonderful themes throughout the day. I've only got a few minutes to sum it up, so I'll try to encapsulate the day rather than go through each lecture. One of the themes in the day was why Wales, and kicked off very nicely with what's going on in Wales from Helen Thomas, the CEO of Digital Healthcare Wales, which was quickly followed by Michael West, reminding us on the importance of compassionate leadership and the evidence basis for compassionate leadership, which I thought was quite remarkable. Most of us in our jobs want to handle our workload. We want a sense of belonging, to work in teams, and we want to contribute, and for that contribution to be recognized through learning and development. And if there's one thing about health data and digital work, it is the teamwork. It's a socio-technical journey, and I thought that was a very sort of anchoring moment for the day, reminding us that this isn't all about data and pipelines and digital. This is actually very much a people process. Moving on from that, Ethan Evans reminded us of what our common goal is in global health data, and that is to improve the health outcomes of our people and our populations. And how do we get there? We get there through actions, and actions require decisions. But before you can make a decision, you need the information. And you need all the information, not some of the information. And data alone, parts of data alone, is not enough. So all the information needs to be collected in one place, and obviously our systems are designed to actually collect all the data in one place, and we need to look at interoperability of those systems and the standards that we use to actually speak a common language. And I thought there was some nice analogies from Ethan around how 8 languages between different families need to be translated in multiple ways, but actually our systems, our interoperable systems, need to be able to speak the common language. Then we've sort of touched on the use of data and the importance of patients in informing us of what is appropriate use of data. The 4 principles of use of data, obviously for direct care in healthcare, to actually build a more intelligent health system, so to understand our supply and demand and be able to target maybe how we can get ahead of that and we'll focus more on prevention. We all have health systems, but I'm afraid health systems are largely disease systems where we treat disease. We don't really have a prevention-focused health system where we actually look to improve health and maintain health of populations. And that was picked up later in the day when we started talking about the social data. And as we all know, the social determinants of health are approximately 60 to 70% of the determinants of health. And so it's the importance of thinking about health data as well as social data is very important in terms of improving the health of populations. The other two components, if you like, of the use of data is value, and a lot of value lies in prevention. And so those two things are inextricably linked. And then the fourth component of the use of data is research and innovation. And how do we foster an environment where we leverage new technologies to improve health? There are a number of new technologies coming down the pipeline, such as genomics and artificial intelligence, and how we actually build our system, our governance frameworks to incorporate these and to actually introduce these into the health system is a challenge for all of us. It's a common challenge, but it's also a fantastic opportunity. The UK Four Nations panel that Rhidian referred to yesterday was an excellent insight into where we are across the UK at the moment. In the UK, we're sort of building the docking station in the public sector, the docking station to enable collaboration with the private sector, both the life sciences sector as well as the technology sector, but also the third sector. And the third sector can help us bring patients into the center of that. And through that collaboration, 3 ways, we can actually build a process that can not only foster innovation, but also help us design a better health system. That reimagining of health system is really important, and maybe that's something that we're not currently focused on. Maybe we're so focused at the moment on actually digitizing the current process rather than actually reimagining how technology might actually help us create a different future. That's something we're all committed to moving to. AI is a common opportunity for all of us and a challenge. The governance frameworks for AI across 4 nations are being put in place rather than currently existing, and technology companies are exciting both the public, ministers and healthcare professionals about the potential of AI. Unfortunately, the governance structure side of it also needs considerable consideration. There is a standard innovation process, if you like, for the evaluation of the risks, the benefits and the value of AI, which is an important thing for us to bring all stakeholders along with us and to help educate decision makers, whether they be patients, healthcare professionals, or more senior leaders. We have the same issues across the 4 nations, and because we have the same issues, greater collaboration across the 4 nations and across perhaps globally would be helpful. If people are hearing a similar feedback from the experts on the ground who are actually doing the work, I think that would be a very good step forward, if you like, on considering how we actually deal with some of the opportunities ahead. We had a nice reminder of the importance of or the potential of precision medicine, particularly in rare diseases and cancer, where these are global considerations, and therefore the federation of data and actually the contribution of data globally from citizens around the world can help to accelerate our ability to actually leverage technologies and deliver precision medicine around the world. That requires considerable technological interoperability on the background, and we were reminded of the infrastructure that's needed, both on the governance side of data as well as on the technical side, to actually act locally but think globally. Trust and transparency was a major theme throughout the day, and we have each country around the world has its own with local citizens is very important, and then that transparency globally, where data goes and what it's being used for, also was mentioned as being very important. And if we're going to realize the benefits of innovation, we need to think globally and act locally. In the afternoon, we had a wonderful talk, I thought, by Steve McFeely, who was the Chief Statistician Officer for OECD and previously at WHO. And he reminded us of how science and the scientific process is essential, if you like, to understanding data. Science is the process of going from uncertainty to increased certainty, but almost never certainty. And it's that process of actually trying to get more and more certain about what the data is showing you. And it's not the data that should make the decisions. It's always the decision maker, informed by the data, that should make the decisions. When we move into algorithmic decision making, we are removing the decision maker often from the process, and we have to be very careful about the human impact of that. And I thought that was a very poignant and important message for us from the chief statistician from OECD. Just checking on some notes here, because it was a long day. So digital governance came up quite importantly. Who gets to decide? What say does the individual patients have, individual citizens have in the governance of their data? And I think that's a very important aspect. And then the laws, there's law, and you can comply with the law, but then above and beyond that, there's the ethics. And we had a nice presentation from the information governance experts in Wales about the Welsh Accord for the management of personal information. And they reminded us that collaboration between the ICO, which is the regulator for information governance in Wales, along with the ethical side and use of data, was very important, and that helps us, if you like, demonstrate our use of data back to the public and maintain that trust. As we all know, once you lose trust, it's very difficult to regain it. So we must take these steps carefully and actually ensure that the citizens are with us in how we use data. We had a nice conversation about what we learned about the pandemic and how do we build on our lessons there. One of the key themes for me throughout the day is this digital infrastructure that we're building for health is clearly a national critical infrastructure. We don't often think of things put that firmly on our plates, and maybe we've gone back to normal rather than actually accelerated our vision to actually build that national critical infrastructure. Importance of health data and its potential impact across infectious diseases as well as chronic diseases in the future. We had a wonderful opening from Andrew Rodman at the chair of SNOMED, and has a fantastic background in our health, our future health, which is a large prospective study in the UK. And also Andrew has a long-standing background in industry about the importance of data sets being able to be integrated and used in a longitudinal fashion to provide us insights, and therefore the common languages that needs to be used and the interoperability of the dictionaries on the background that would support the proper analysis of data. I thought that was, from a technical standpoint, was very, very important. And also then, obviously, if we build that common language, how that can inform and improve AI, because we all know that it's the quality of data that's actually going to improve any algorithms that we might develop, and therefore we need to look at the quality of data that actually go into these algorithms. And then coming back around, I think towards the end of the day, I think we were summarising over dinner what was the take-homes of the day, and I think that this is an exciting journey. There is a lot of work for us to do, but that work gives us excellent challenge. And I think perhaps for me the most sort of important bit of it is that it's the people side of things that really will make this happen. How we work and collaborate together as people, as citizens, and bring stakeholders together and take people on the journey with us. There's a significant amount of interaction and learning opportunity for us all to work together. So with that, I'll say thank you very much. I hope I captured the day, and I'll hand back over to Rhidian to look at the future of day 2.
Thank you, Matthew. And Matthew leads the Intelligence, Information and Research Division within our organisation, and you can see he was paying attention as summarised the activity of yesterday very well. So I'm just going to give you a little 2-minute story about Lavernock Point, which is just round the corner. I don't know if you know why Lavernock Point is significant, but it is in 1897, Marconi sent the first wireless message across water. And why did he do it across water? Well, he did it across water because no one believed there weren't hidden wires. And this is about trust. So the technology was introduced, the public was skeptical, the engineers were convinced, and they needed a methodology to demonstrate that it worked and that it could be trusted. So today, the future-facing and dialogue discussion is about AI, a new technology, the data, the methodology, and trust. Do we trust it? And I think we're going to have some exciting discussions about what can we trust at the moment, and what guardrails might we have to put in as a global community to ensure that that trust is maintained. So understanding, evidence, and the translation to delivery of improved care is what we as a community are trying to do, to use data to add value to the citizens that we serve. So some exciting sessions ahead today for dialogue. Learning from and learning with others is always an opportunity to grasp. I hope you enjoy the day.
Thank you so much, Matt and Rhidian, for this brilliant opening. We couldn't have a better start of the day today. So it's now my great pleasure to introduce our keynote speaker this morning, Dr. Emma Gordon. She's Director of the ADR UK Strategic Hub and Director of ADR England. She is responsible for setting the strategic direction for the program, leading on the coordination of the partnerships and engagements with senior stakeholders to improve access and analysis of administrative data to improve. The floor is all yours.
Yeah, lovely to be here, and I'm coming at this from a whole different perspective, but health data is incredibly important to what we do right across ADI UK, and I'll give some fantastic examples of how we've been able to open up access to that for public good research. So just before I start, the ADI UK partnership is UK-wide, and it aims to have government civil servants working with academics both to open up access to the data, link it, make it available for wider research use, and all of the data linkage projects we fund end up with data being made available for wider research use in all 4 UK nations. And then we also fund communications and engagement, public engagement, research using these new flagship data sets, and it's now a massive operation, which I'll say a little bit more about at the end. So when I talk about administrative data, it's literally any form of data that is collected off a government system or service that we're interested in. So the types of data that we've linked to date have included education records, Ministry of Justice courts and prison service records, health records, employment and earnings, and census responses. And I work at the Economic Social Research Council, not the Medical Research Council. That's quite important, because when it comes to health records, as a programme, we're not interested in just linking health data to health data or making health data available on its own. It's that linkage across to other forms of data. And that's where you get the really interesting insights about people's lived experience, about their background, about other things that might be impacting on their health or other aspects of their lives that might mean treating their health might be more complex. And if I explain briefly why this is so difficult in the UK, it's like a microcosm of the world. The UK is made up of 4 nations, and we have devolved government, which is a brilliant thing. It also makes it much more complicated to link data, because with things like education and health data, which are entirely devolved, you have 4 different education systems, 4 different health systems, all working to each individual government's priorities, not some central organised thing. So the data is split. Got things like HMRC that are UK-wide, more or less, and justice and benefits data that are somewhere in between. So it's really, really complex. That's why we have one trusted research environment in each of the 4 UK nations, and the Wales one is run by Swansea, the Sale Data Bank, and it's really important that we have and forms of research that we fund, so economics, criminology, education research, because we absolutely recognise right from the very start of our programme that although it's absolutely lawful for us to be making this data available to researchers in de-identified ways and linking it and everything, we have to work really hard to maintain that public trust and the social license to use this data, because we are one bad story away from this all being shut down. And we want to talk about the positive use of data, and really good to see colleagues from Use My Data over there in the corner, because it's a really, really important charity who are promoting the public good that can be done with this data. We get a lot of scare stories, but you know, you need the power of the good stories to kind of counterbalance those. And I'm not pretending there aren't risks, of course there's risks, but you know, this is our insurance policy. This is how we make sure that we demonstrate to parliamentarians, to the public, to researchers that we're using this data responsibly. And so a really good example of how we do this is if we're doing research on young people, vulnerable young people, we involve them in the research. And this is an example of some fantastic work that was done with our Northern Ireland partners and the voices of young people in care, and getting them involved in the co-production of not just the research project, but also how you talk about it in the public domain. And we've done this within our team as well. So, you know, getting young people involved in, you know, kind of making sense in their own language of the types of research outputs that we produce. Because at the end of the day, if research about people doesn't speak to them and isn't understandable to them, we're not doing our job. And so, yeah, the vision that's now being realised, and was set up in 2018, this has been a long, and there were many programmes before this that attempted to do what we're doing now, but we have really difficult to get access to government data. Within the civil service, it's difficult to get access to government data as well, but we're helping resolve those problems, not just for academics, but for civil servants as well. And we can fund government departments and organisations to work with us. So the ask isn't, can you prioritise resource to work with us instead of, I don't know, fund a prison service. That's not the, you know, the balance that we're asking organisations to do. We will fund them if they will work with us to open up access to data. And because we've got the Digital Economy Act, that's actually been really, really powerful because it's one legal gateway that we can talk to I alluded to some programmes before HTAi UK that had tried and sort of not quite got there in tackling these difficult problems. One of the case studies that really proved the value of what you can do when you link health and administrative data came from Wales, and really alcohol-related deaths in Scotland. And they introduced a policy, and then they asked our partners in Scotland to evaluate the success of that policy, and they were able to demonstrate that it did lead to direct reduction on alcohol-related deaths. And it was that evidence that gave the Scottish Government the comfort it needed to continue with that policy, and it's been looked at in various countries around the world now. One of the data sets I feel most proud about, because it's ADR England data set and it's been really, really difficult to deliver, is linking decades worth of education outcomes data with decades worth of health outcomes data. And there's a whole series of research questions you can answer using this, and researchers can apply to access this. It's free to access. This is through the ONS Secure Research Service, based just next door in Newport. And it's a fantastic data set. And the early research that's done, there's about 50 approved projects using this now. But one of the earliest research projects that was done looked at different education outcomes at age 7 and 11 by gestational age of the child. And I was always told, as you know, when I was pregnant with my children, that if your child is born between 37 weeks and 42 weeks, there's no difference for outcomes of your child. Well, it turns out actually there is. If you look at it at the scale that they're able to look at it from e-child, so you'll see the black bars, they're education outcomes at age 7. And there's a significant difference between education outcomes of children born at term versus ones born at 37 weeks. That does reduce down the blue bars by age 11. But we now know this, and educationalists can do something about it to help those children born at earlier gestational age to be able to catch up with their peers. And anyone from cancer research will know that it's a really big thing, understanding the impacts on different family members when a child or an adult has a health condition. Well, this is now possible within eChild as well, so you can look at you know, the impact on siblings of a child having a significant health condition and the impact on their education outcomes as well, which is incredibly valued because there's a heck of a lot of evidence to support that this is a big thing, but we've never been able to look at it at a population level before, and we can now. I just want to talk about the Ministry of Justice Data First programme as well. So this department has gone in the last 7 years from zero to hero, I would describe it as. So they actually came to us and said, you know, we'd love to give academics access to our data. We don't even have good access to our data because what we've got is 50 different streams of administrative data coming into the department from all the different parts of the court services, so criminal courts, civil courts, family courts, probation services, prisons. There's no unique identifiers. We can't make sense of it, so how on earth can we give access to researchers for it? We funded them to work out the pipes, if you like, and work out how to link that data. As a byproduct of that work, they came up with a Splink algorithm, which they made available to download. It's been downloaded across the world over 12 million times now, and it allows fuzzy matching between data sets where you don't have a unique identifier, essentially. And it's really quick compared to other algorithms for doing this. And yeah, they did what they set out to. All of these linkable data sets have been made available to researchers, and they're now also sharing that data with the Sale Data Bank in Wales because they want it to be able to link to things like census data, so you've got really good demographic information on people, and also health data, most importantly. And if you want to find out about public engagement we did around this, is a really fantastic podcast episode with Amy Summerfield from Ministry of Justice being interviewed with David Maguire from the Prison Reform Trust about how we embedded that public engagement through civil society organisations into that programme, and it's a fantastic episode to listen to. And if I just give you a sense of where they've got to now, so they can now track people through different parts of the service, which all of these things were separate before, and you couldn't tell, you know, which groups were in which. Now, clearly John is a fictitious person, but I'm just going to tell you about the types of journey that you can map now. So if you think about this person, John, entering the family court as a child and being taken into care, and then later on in his childhood he commits a crime. His case is heard in the magistrate's court. It turns out it's quite a serious crime, so he ends up in the Crown Court. He's taken to prison, and then he appears in the prisons data set. And then within 8 weeks, he has an assessment, and he's found to have multiple complex needs related to mental health and substance misuse. This is the first time that Ministry of Justice will know this person has complex health needs. And after completing half his sentence, he's released on licence, he ends up defaulting on his rent, and the whole cycle starts again. And this is a story of, unfortunately, a lot of people who end up in the prison system, and it starts there, back there, with the child being taken into care. And bearing in mind, most children don't get taken into care because anything they've done. This is adults around them. This is the cycle that Ministry of Justice wants to break. And they've been asking to link mental health data to their justice data for at least 4 years. They haven't got anywhere. Hopefully that's going to unblock. But this is like the missed use of data, what we're not, the types of research and insights that we're not allowing if we don't try and, as a country, if we don't try and fix these problems. So there was a House of Commons Justice Committee report a couple of years ago that looked into the impact of mental health on prisoners, And it estimated, it's got this fantastic quote that the Ministry of Justice don't know the extent of mental health care in prisons. And you can see why, because they only find out about it kind of retrospectively. And Kate Davis, Director of Health and Justice at NHS England, estimated that 70% of our men and women at any one time will have a need around mental health. That is absolutely massive. And if we look at that compared to Scandinavian countries, if 70% is at any one time as a kind of minimum level, in Norway, Denmark and Sweden, their rates of people coming into prison with a mental health condition don't really get above 40. So it really, as a society, you've got to ask questions about who are the people who are ending up in prison and what support isn't being given to them before then that means they then go on and have this terrible thing happen to them in their life. Just want to talk now about missed use of research a little bit more. So findings from the National Evaluation of Liaison and Diversion Services in England. This was a report that was commissioned by NHS England, and they commissioned RAND to complete it. It ended up taking RAND 4 years to do this evaluation. Liaison and diversion services are basically looking at, potentially vulnerable groups and how you can support them so they don't end up with the worst outcomes in justice system. So exactly what we've been talking about, basically. It took them 4 years to complete the evaluation, and even then they couldn't get hold of all of the data from NHS England that they wanted, so it had to be a bit of a fudge. 4 years and a lot of pain, and they swore they'd never do it again. Now, hold that thought. On this side of the screen, this is a picture of an asbestos mill near where I grew up in West Yorkshire in Hebden Bridge. And I remember this run as a mill, and my mum was a GP, and she was part of the group of people who were working for years to try and prove the link between asbestos exposure and mesothelioma, which is a really, really nasty cancer, which you will have a horrible death from, essentially. And I was interested, could we solve this problem earlier now rather than when they were trying to do it in the 1980s? Hold that thought. So now we've got the Cancer Research UK CD3 programme, which is a £10 million programme, which ADI UK are a proud supporter of. And it's going to link up, it's going to do a whole load of things. Ashley's involved. If you want to understand the details, then please do ask him. But essentially, it's the reason why we were really interested in getting involved is they are thinking, well, we've got so much more data available to researchers. Instead of thinking about cancer in terms of genetics, can we think about it in the context of the person and all of the other social factors in their lives that mean some people might be more likely to get certain cancer or die of a certain cancer? And I said, absolutely yes, please go and talk to the SAIL data bank because they've got access to all this cancer data and they could really help you to do some great stuff here. So as a kind of pilot project to demonstrate what could be done, SAIL researchers looked at, and because Wales is a country of 3.1 million people, so we could only look at the most prevalent cancers and really drill down into details with a whole load of demographic information. But we proved that it was possible to do this and that it came out with some really good insights. So in screening programs, people who are less likely to take part are people from deprived areas, younger individuals, people from certain ethnic groups, people who are single or solo living individuals, and people who have existing health conditions apart from cancer diagnosis. Now, if you know this and you run your screening program, then you can start to target certain groups in society so that they don't end up being the ones with the higher mortality rates from certain cancers. So this was enough to convince CIUK and CD3 that this was worth investigating further. Because if you think that that's a typo, that should be 3.1 million for Wales. If you think about that size of the population, and the population of England is 57 million pounds, at the moment we've done breast and bowel cancer, you know, and just scratch the surface on what's possible within the SAIL data bank. If we could do this for English data, then think what other deep insights we could get to if we could link cancer incidence and screening data with a whole load of administrative data sets as well. And retrospectively, could we have evaluated the risk of asbestos exposure faster? I did a little bit of research on this, you know, very quickly, and I hadn't appreciated that, you know, it was quite some years ago that the link between asbestos exposure and cancer were sort of suggested. And that was really sort of, this paper in 1935 was the first one that properly suggesting this link between mesothelioma and occupational asbestos exposure. It took another 70 odd years until it was actually banned. And this is a time, it was the early 80s that my mum and various lawyers and other people were trying to sort of prove the link in the court so that the families impacted on it could get compensation, many of whom died before they got that. But yeah, could we do it faster these days? Are we facilitating that kind of research that you can do this kind of evaluation quite quickly? I'm not sure actually, but I think we probably should, and we should have things set up prospectively so that we can look at these things when a risk is identified. But yeah, looking forward, we've got refunded for another 5 years, going up to March 2031, so 168 million. There's a heck of a lot of things we're going to do with that funding, but it basically means more data linkage, more training capacity building. We've got PhD cohorts existing. In this investment period, that's going to get bigger. And yeah, more funding for impactful research and insights that improve lives. And this was all based on an interim evaluation of our programme, external one, that we did last year, commissioned last year, that said that very conservatively, for every £1 spent on ADI UK, there's returns of over £5 of benefits. And I think that's really, really important, because at the time in this investment period where we were making such a big thing about things like public engagement, people were looking at that and saying, but isn't that an expensive, nice to have? And absolutely not, because if we didn't have that, we wouldn't be able to demonstrate those benefits, because we wouldn't have been able to unlock so much data. Thank you.
Questions in the end,
yeah.
That will be moderated. Thank you so much, Emma. We are going now to pass to Tiago Taveira-Gomes, I think already online on Zoom, for another presentation, and then we'll get to the Q&A session that will be moderated by David Wynnum-Lewis here, and then introducing also a case study, and then some questions from all of the participants and also online participants, as I'm sure Padma is already taking care of our Zoom participants. And unfortunately for LinkedIn viewers, we are not able to address your responses on the comments. You had to join Zoom in order to have your responses admitted in this summit. Tiago? Are you now online?
Good morning.
Yes.
Can you hear me?
We can. The floor is all yours. I would skip the presentation to save a little bit time, but you can introduce yourself also if you need.
Thank you so much. So pleasure to be there. Unfortunately, due to family circumstances, I had to leave earlier. But thankfully, we can do this online. So my name is Tiago Taveira. I'm a family physician and representing here MTG, one of the sponsors. And I've been very active in trying to solve a complementary problem or do a complementary approach of what's been discussed so far on how can we make healthcare institutions ride this wave of data and AI in a way that they can actually um, transform themselves from within. So that's pretty much what I'm going to talk about, what we've been doing mostly in Portugal. Hopefully this can be useful and translate to other regions. My presentation is there, I see it. So as a family doctor and as a doctor, I think we've always been haunted by the issue of efficacy in trials and the effectiveness in the real world setting. So not only we need to understand that whatever technologies, health technologies we use, they actually are causal on the effects, but we also need to work towards making sure that they can derive the value that was found in these controlled environments into the real world. And that for me is a challenge that is growing bigger and bigger, and maybe one of the areas this is been mostly applied and most work is done is in the drug side. But if we look at EHR systems as health technologies, which is more and more the case, we see also the problem of effectiveness, and digital health tools and mobile health tools also going on that direction. And more importantly for me at this point in time, AI solutions suffer from this problem as well. And for me, what makes it even more challenging with AI is the fact that the algorithms that provide the greatest value, they are potentially non-deterministic, which means the capability to assess effectiveness becomes more and more challenging across time. So in my view, we need to find ways to scale capability to measure effectiveness in a way. And why is this a challenge that I believe we need to focus on solving with additional avenues? That's because when we talk about the real world, it seems that there is just one real world, but in fact, in healthcare, we have many real worlds. And these real worlds, they vary across many dimensions of the technology applied to the different context. But this context is also broken down in different items, the clinical setting, the kind of progression of disease, acute versus chronic, etc. The degree of skill where the technology is applied in terms of specialist or generalist healthcare providers, the setting in terms of geography. So all of these things have an impact, and they dent the effects we see, and they dent the effects we see in different ways in each setting. So I've come to believe more and more that the healthcare setting and the real world is actually a localized, and it's very hard to describe the real world as a single set of rules or generalizations. And so this would be already very complex, but then we have also other vectors on the context that change across time, such as technology, as we see now with AI, the culture shifts in mentality, in all we see across the world with the big inflows and outflows of migratory activities, the politics that also, in my view, getting more and more volatile and creating also impacts on the way healthcare is set up, the guidelines that change and evolve, and now even more with AI applied to produce summaries of what would be applied to patients, that will have even more implications. And also at the same time, the changes in the environment that we see, and that we already start to see in some disease areas like respiratory and others, that environmental factors will play a bigger and bigger role in health in general. So I think we need to look at the real world as kind of waves in the ocean, where the waves, they actually are composed of fractal waves and smaller waves. And the distributions that govern these waves, they are very likely hard to be known or to be static at a single point in time. So I've come to believe that the one way that we should look at the real world is assume that it is non-stationary, meaning that the latent variables that govern all of these things that I was explaining, their distributions change across time in ways that we cannot directly measure, which means what we know today is not given that it will hold tomorrow. And that, if we again speak about AI being non-deterministic, gets inflated as a problem. So this fact of localization and non-stationarity makes it very hard to create generic solutions, one-size-fits-all solutions, one-size-fits-all approaches. And it makes it very hard, and I'm sure this must have been felt by many of you in different contexts, to find ways that we can solve problems using a silver bullet. So in this view, the gap that between effectiveness and efficacy will keep growing if we don't take a different approach on working towards this problem. And so the way and what we're doing, and I'm also a professor at University of Porto. I taught a long time preventive medicine and digital health and AI data science. But at some point, I decided that the real place where I should be teaching is on site with the clinicians. And so back in 2024, I started visiting hospitals and finding potential talent hidden in the different institutions of healthcare professionals that would be the first generation, let's call it, of local talents on this area of dominating not only the clinical aspects, but also progressively more and more technical aspects relating to data, relating to system development in different proportions or degrees. Because what we feel is that if the problem is very localized and there are many versions of the problem, we will need many solutions, and we will need many solutions that need to change and evolve across time. And the only way I see feasible for that to happen is really to be able to train healthcare professionals at scale so that that can be something that evolves across time. And very importantly, and I felt this also in my path as I step away from being a clinician, finding ways for this to be possible with people that actually keep clinical activity is really important. Because I felt on this transition more to the technology side that I've lost the touch with reality. And at some point, even I, as a family doctor that is practicing and creating these things, felt like I'm not the most relevant person nowadays to actually implement what needs to be implemented in each place. So we believe, and we are working actively on creating a generation of professionals and finding the talent to help these professionals be able to generate evidence, conduct implementation science studies that can quantify impacts in automatic and continuous ways. So I think we need to shift in a direction where we become capable of measuring many things locally, but also in an automatic fashion, and make sure that these individuals are the key for that to happen. So this pretty much goes in line with the mindset of the health learning system, which in a way kind of may feel like utopic. But we are very passionate, and this is pretty much really the life mission I kind of put in my back, that if we can create this kind of talent and capacity at scale, I believe we'll be able to create sustainable learning health systems that actually evolve and progress on their own and that learn from each other. So one of the ways we got into this was through the activities that took place here in Europe in the past years on Eden, mostly on Eden. We were part of this and conducted a lot of data activities for a number of parties in Portugal and Sweden and Switzerland and other countries. And the place where we started all of this was in ULS Matosinhos. So Portugal recently reorganized into 39 healthcare regions that provide primary and secondary care. And this was the first one established 25 years ago. They had a culture that would be a fertile soil for such kind of approach, ambitious approach. And so in this tiny speck you see there, this is where we started back in 2020. And this has been proven quite successful. We trained a number of physicians, nurses, mostly physicians and nurses, to collaborate in evidence generation and become capable in evidence generation that has been resulting in many publications, some of them now fully autonomous. And that during 2023, that expanded to 3 more centers. And right now, this has scaled to cover about 75% of the country. Of course, this is a huge endeavor, going all these places, starting to train this first generation of professionals, but the goal is that they will become not only capable of implementing, but also of teaching the second generations locally. So we're pretty much trying to put create the snowball going downhill and then hope it will grow on its own. So right now, our hope for this year is to get the first submission of one of these groups that is fully autonomous without our help, to make sure that actually this knowledge is getting anchored. In parallel to make this work, we've developed also a technical approach that takes into consideration some of the mindset around trusted research environments that exist in these institutions, but also the idea of sandboxes or digital twins of the infrastructure. So the idea is that these professionals, they can learn how to do things without being exposed to systems in the hospital or even the research environments. They can work straight on sandboxes that have digital twins of their institutions with dummy data or mock data or any kind of data, really, quite frankly, nowadays with large language models. One of the great things to use large language models, in our view, is to generate very trustworthy, it's not the word I'm trying to think, data that really looks like it's true, but it's not. So Gemini and others, they are very good at doing that. And so that is enabling these professionals to develop their algorithms, their analytics, as if they were inside the institutions, even if it's OMOP data or any other kind of data or any other kind of systems, it doesn't matter. You can replicate whatever is the reality and give them a copy of that without any sensitive assets. And what we've been finding out is that for many use cases, including more advanced use cases such as developing AIs or even dashboards to help on local control of things, there is a learning curve that can be surpassed, and that most of the use cases become easy to implement with this approach, which then the actual output of what's developed can be internalized on the TREs in automatic fashion and executed without human intervention. And this is, the great thing with this is that if the talent that we find is a talent that is still very low-tech savvy, the talent can grow without being touching any privileged resources and imposing risks or big risks for the institution. This is zero risk approach. And we're building all of this on top of open source software that's around. We're very big believers of open source software, mostly Apache Foundation and Cloud Native Foundation. Hopefully our developments will one day also be graduating on these very big foundations. And it has yielded some interesting work that has potential, and the setting for it to happen is usually local. For example, the application of a heart failure guideline into the healthcare clinical notes to understand where the patients are not being treated according to the guidelines. Once they presented with some criteria of interest, what was actually the action taken? So these kind of studies that are very localized, they create a huge traction with clinicians because they are seeing the work or the output of their work in a way that they understand in their own clinical language and setting. And so what we've been seeing of this is that the next step is always, how can we change our practice? How can we make this better? And because we're doing this and training people to do this by implementing software that is automated, once a study is there, the study can be executed many times. So they can see this change across time. We're also teaching people to build dashboards to help conducting their activity. This is for complex chronic patients that are very hard to manage, very hard to find on the healthcare system, because the criteria to find them are very complicated and time dependent. And by teaching professionals to develop this sort of tools, this completely changes their capacity to deliver care and to improve. And this is also an example of the kind of things that clinicians usually want a lot to see, how their prescription patterns is happening before, after a discharge, in this case of being acute myocardial infarction, and showing that there is so much more to be done in terms of improving the quality of the prescriptions according to the guidelines. So we think that there is a very fascinating road ahead by trying to focus on raising these talents. And if we go in even further on AI, I think AI will be a tool also to incorporate in such a manner. And I understand that when we speak about personalized medicine, we always tend to think about omics and tailoring treatments to patients. But as a family medicine doctor, I think that there is a huge opportunity to do personalized care by making sure we apply the care that's required to each patient at each point in time in a matter that makes it easier for them to actually to get the maximal benefit of that care. And that may go into other spheres that are also very far away from the omics and depend much more on the context of where care is provided. And also focusing on that, I think that raises the passion and the good feedback that clinicians get by being able to do that. And so for this, I think we need to really focus on having these clinicians develop such capabilities that allows them to generate and also assess what the algorithms are doing across time. Because I think that we will have more and more difficulties in explaining having algorithms and understanding the inner workings of algorithms, even though they can seemingly using LLMs justify why they reason in a certain way. The actual inner working of the algorithm is still a black box. And I think one of the ways for us to build trust on AI at scale and at the local level is through applying these principles of evidence generation to AI and continuously monitor AI. So we don't really need to understand why does it work like that, as long as we know that the output that they're doing is within an error rate, that it is at least the same error rate as the human. So by creating that kind of guardrails, I believe we will be able to scale AI more and more into clinical practice. And also, here I find another very interesting avenue of trying to go in the direction of creating ultra small language models that can do tasks very efficiently, very, very niche tasks. And that can be done by what's called the model distillation with the teacher-student models, pretty much to create very, very, very niche models that can do something very, very, very accurately, very small, very simple, but very accurately. And they will not cost huge GPUs. They can be done on CPU-bound hardware, and they can help AI also scale without the cost of maintaining more and more infrastructure, which is nowadays a huge problem. And all of this can be done at this point in time with hardware that is available on the cloud, or with some high-end computers, and with some of the local models that already exist. And it's a matter of teaching people. Again, I see this huge opportunity. And the final reason I wanted to convey about why this is important is because the AI suffers from what I call the curse of convenience. Because it's so convenient, we just delegate more and more of our cognitive tasks to the AI, and tend to rely or over-rely as we build trust on the outputs. And of course, that is not both safe, nor is it desirable for keeping and creating professionals that are more and more knowledgeable. So in a way, helping clinicians develop these skills and work these skills out during their as part of their job, also I think are ways for them to retain knowledge and develop a very critical approach to tools and systems that will also help them keep the correct development of their mindset and not be prone to this curse of convenience. So this is pretty much what we're doing, and I hope this is can be helpful for you. And if any of what I said is something that you'd like to discuss, I'd be very happy to follow up with any of you. Unfortunately, not in presence today, but it will be my pleasure to see if these kind of things can be scaled to other regions. So thank you so much.
Thank you, Tiago, for this enlightening presentation. I think we are so blessed by two keynote presentations this morning that give us lots of food for thought. We have now time for Q&A on both presentations. I'm sure we probably need 30 seconds to reflect a little bit, but I'm sure that some questions will arise here. And also online in the audience, Padma, if you can manage the floor there.
No questions online.
Okay. Any observations you'd like to share, Padma?
Yeah, so thanks a lot, Paul, for asking. Starting with Emma Gordon's presentation, it's really very impressive, and driving future impact and the new investments for ADI UK. That is really impressive, and I think, sorry, there is a lot of echo.
Yes, Padma, you don't have the camera on, but
Okay.
maybe we can have here also some comments from now. Anyone?
Yeah.
Okay, we have here a comment.
Question to Tiago. That was a fantastic presentation, really innovative and really intriguing about how we build a learning healthcare system from the bottoms up. I thought some fantastic ideas there. Quick question, in our clinical practice, we often engage with patients in a shared decision-making process. So the data that the healthcare professional might see on their own practice is obviously insightful in terms of how to optimize that discussion. Often in that shared decision-making consultation, we also need to provide the patient with the information necessary to know what the guidelines are, know potentially what best practice or standard of care practice should be. I wondered in your exploration of how to do that from the bottoms up, whether the patient also being part of that decision-making process of which guidelines might be appropriate to them as being considered.
Yes, absolutely. That makes a lot of sense. And I do believe that more and more we need to involve the patients in shared decision making, mostly as the patient also gets growing and growing health literacy and becomes more and more capable of participating on the decisions in a very grounded way. So I see that this kind of approach has a twofold implication. The first one is helping healthcare professionals become progressively more mindful and scientifically driven on their assessment of evidence, and so being in a better position to discuss and recommend what to do based on the guidelines and the recommendations. Because as we understand, without the proper assessment of what made such recommendations be developed, sometimes it's hard to understand for very specific situations whether or not that applies to the patient in front of us. So that's kind of an effect that I believe will happen with this progressive scientific reasoning and involvement in making the healthcare institution progress in that regard. And the other is also in the ability to tailor the guidelines or to extend the recommendation into the realm of things that are not there or not possible to define at such a global level. And in family medicine, we did found a lot that so many cases required for us to rely on our empirical sense once you understand the context of the patient is broader than what the guidelines say. And in that sense, providing healthcare professionals and institutions with the availability, the capability to create such local evidence, even though it's not ever going to be of such a high quality, I think it will still be better than just relying on empirical observation or clinical opinion. Um, and for that, I think that decisions will possibly become more and more adequate to the patient, and also in that way go into the direction of personalized medicine that I was alluding to. So I fully believe we need to do this engagement with the patient.
Tiago, I have one question. I couldn't ask before. So, how can continuous evidence generation and implementation science approaches help overcome clinicians' skepticism about relying on the prior AI performance studies when adopting AI in the clinical setting?
Yeah, so that I also think if we involve the healthcare professionals to be part of the process since the beginning, I think that changes the rules of the game from the start. So we put people or try to put people on the side of creating the solution instead of trying to push through their resistance once the solutions are rolled out. Uh, and I think it's true and it's quite justifiable that clinicians are wary of generalizing results of AI algorithms in terms of prediction, for example, of things that they have seen or are published from other databases or other regions. Mostly when this kind of data is very, very reliant on context. So if we go to very, low-end genetic data, or if we go to imaging, the imaging is quite invariant across geographies and physiologies. So evidence that you may found there is very likely to hold, and you have these very interesting results from the federated learning work that's been done on COVID with X-rays that really show that you can find a global model that behaves better on each place than the model just trained with that data. And what that shows indirectly is that there is signal that is generalizable. But that's because it's very, in my view, ingrained in either genetics or anatomy or physiology. if you go into the problems that are dependent on context, on how care is delivered, on how healthcare systems are organized, and on what drugs are available, then the problems take a lot of context that is very easy, very hard to generalize, as I was alluding on my presentation. And so that requires this local validation and this continuous validation in an automatic fashion to really showcase that what we see that the model do is what the model is doing, and it's not shifting away, because the world will keep changing. The way we drive care will keep changing at a fast rate. Physiology and genetics, not that I am aware of, will change so fast. But all these things, they change fast. So if you don't track this performance, it's very likely that you'll find these drifts. That's what they usually call the model drifts. And that's also very interesting. There's a paper in Nature, from 3 months ago, showing that after a few years, all models drift and lose performance by a non-negligible amount. So we really need to create this approach of continuous visibility on model performance at the local setting, in my view.
Thanks a lot, Tiago, for that. But continuation to what I asked and what you just...
We have
sorry.
to. Sorry
Okay.
to cut you because we have to
Okay.
leave this. I have here a final question for Emma, but maybe it's not a question. If you had a magic wand, Emma, what would be your wish? And with that, I think we close this fantastic keynote session.
Thank you very much. My wish would be solve that problem about access to linked health data for England. If we had, at the moment, health data is excluded from the Digital Economy Act, which means we have to rely on much older pieces of legislation to open that up, that were designed before the world of trusted research environments. If we could have that exclusion removed, my job would be a heck of a lot simpler. It would be a whole lot more data available for research.
Thank you so much. A round of applause to our keynote speakers, and let's now start the second part of this opening session now with the lightning talks. I think we have here already some of the speakers in the room. Louisa and Nolan. A round of applause to Louisa from Public Health Wales. Thank you for joining, Louisa. We'll put the seat arrangement here, see if you don't. You need to do slides, you can use then the lectern. And have you shared your PowerPoints with Rhys? Okay. So David Wynnum Lewis is going to be also a lightning talk speaker last minute because Elena Petelos is not able to join. And we have Iñaki Gutiérrez also. That's going to be the last in this session to speak. Last to speak has a bigger responsibility. But Iñaki is bringing the perspective from also another nation, Euskadi, in Spain, and will bring a perspective on policy making and technology assessment from the end. So I think, oh, and obviously Mike Cooper, yes, thank you so much, Mike, for joining us in replacement of Adam, but in fact we have better served with Mike. He's the program manager of delivery in Life Science of Wales. Thank you so much, Mike, for joining last meeting from your busy schedule. I know that Mike was also here yesterday. I had good feedback from Mike and on day one, but I'm sure also this panel is going to be interesting and relevant for what we want to accomplish here, driving change through data insights. That's our goal here. David, if you can also take the floor here for the presentations. And Louisa, you want to present from the lectern or from there? Maybe from the lectern is better. Yes, okay, so now we have all the stage complete. I hope you enjoy this session.
I'm just building the tension here. Mostly for me and the technical people, I think. There we are. So, hi, yes, I'm Louisa, Head of Data Science at Public Health Wales. And I'm going to talk to you about data science and analysis in public health. It's interesting, yesterday we were talking about what the definition of secondary use of data is. And we talked about the bit, you have the primary use about directly affecting patients, and then we often think of secondary use being about research, like some of the amazing stuff that Emma's just been talking about. But this more sits in the middle, so this is really about getting the right data to the right people at the right time for people within the health system to help make decisions. So it comes in two parts. What can we do with data? And then at the end, some questions about, really, why aren't we doing more? So part one, I've got a story to tell you. It's quite a simple story, but it illustrates some of these points. So these are, what can we do with the data? Why is it? I thought I had a different slide, actually. I hope I've given you the right slides. Oh, well, probably. Anyway, we'll do our best. So the three things in the remit were, how do we use data to help to understand what's happening? How do we use data to inform decision-making? How do we use it to help delivery? And then what opportunities can we find by using the data for AI and data science? So we start here with a dashboard. Not all dashboards are good. Just chucking data into a dashboard and expecting people to understand it is bad, but this is a good dashboard. So imagine you're a board member at Public Health Wales and it's your first day, and you want to know what's happening across the system in Wales, across health, public health, and also the things outside the health system which might have an impact. So we created this dashboard across our strategic priorities, and the board look at this in every board meeting and discuss it in every board meeting, which for me as an analyst is a success just on its own. And it's had an impact. So the story I'm going to tell you about today is that the board looked at this, and they looked at the excess deaths, and within the excess...
We have to have these for the online viewers.
Oh, sorry. Apologies to the online. Apologies to the online viewers. So they looked at the excess deaths, and really high excess deaths and growing excess deaths in diabetes. Now we know that type 2 diabetes is mostly preventable, which is a public health thing. So the fact that it's growing was something that we wanted to look into more. So this is here. So here, this is. Yeah, these are definitely an older set of slides. Never mind. We'll work with it. So this is about driving prioritization, looking at that, something that's growing, that's a public health issue, excess deaths in diabetes. So the next step was, what is diabetes doing? So this is a pretty grim picture. This is primary care, the counts in the primary care diabetes register over the last 10 years and a bit. And as you can see, simple line going up, not much variation. An increase of 60,000 people over that time, which is an increase of 40%. Most of this is type 2 diabetes, and most type 2 diabetes is preventable. So then, also we have diabetes we know is a risk factor for cardiovascular disease. So we look at what cardiovascular disease is doing. So this is interesting. The cardiovascular disease has actually come down, but then it flattens off a bit. So what's going on here? We know that the treatment of cardiovascular disease has improved, but the flattening off, there's obviously something that's acting against that improvement in the treatment as well. So then we look at this. Why is it happening? One of the risk factors for diabetes, one of the amendable risk factors for diabetes is obesity. If you're living with obesity, you're almost twice as likely to have diabetes as if you're not. And again, pretty grim picture for Wales. You can see the increase in obesity over the last 2 decades or so. So then we look at this, we see what's happening now, but then this was the new bit that we did. And this was really where we began to add some value. People knew within the system that diabetes was a problem. They knew that obesity was a problem. But here we look at the projections, and you can see it's a fairly convincing projection because it hasn't warmed about very much, so it's quite easy technically to do the projection. If we continue, in the next 10 years, we'll have another 22%, an increase, another 22%, the 47,000 people with diabetes. Now, the system's already stretched. We can't really do this. We know that we can prevent some of this. So, these are definitely my old slides. I'm so sorry. I don't want to talk about that. I wanted to talk about something else. So what do we want to do with that? So that slide, going back to here, this slide we took and we presented this to senior leaders. Like I say, people knew that diabetes was a problem, they knew that obesity was a problem, but it was until they saw this thing, at this point, showing this slide to the senior leaders, that really kind of crystallized it in people's minds. So we use that to make a powerful case for change. So bring this together, showing this data, telling that story to the senior leaders, CEOs and so on. We brought together the Tackling Diabetes Together programme. So this is a programme led by Public Health Wales. It's across the system, bringing together different people to focus on that problem. So we had three inputs to that really. We knew that 10% of the NHS's budget spent on diabetes. We know that most type 2 diabetes is preventable, and we had the killer stat, that chart. And that really was the bit, bringing those things together, telling that simple story to get people behind some funding as well for the Tackling Diabetes Together programme. I don't want to talk about the things, the actual initiatives too much, because this is really about the data. So the next thing after that was we've identified the priorities using the dashboard. We've made the case, so we're doing something about it. So we are making decisions about delivery from this. And then the third part of this, which if I had the up-to-date slides I would show you, was really about what then are the opportunities around data science and AI. So the things that we're looking at now, this really, even the projection is quite simple stuff, just bringing it together, showing people, telling the story. As a data scientist, we want to do more complex things. So there's a number of things that we now identify that we want to do. So the first one was looking at some demand and capacity modelling for diabetic eye screening to see whether we could get more people through. The second one was to look at what did we do then? The weight loss modelling. So doing some modelling, looking at different thresholds for weight loss drugs, looking at the costs and benefits of those. So these are slightly more advanced methodologies. Then we have some other things that we've just made a start on. So looking at policy simulation, looking at modelling impacts of different interventions, and one that I think is really exciting around the NHS app. So one of the problems with the excess deaths, we can see that we might get excess counts from increased obesity, but why there are also excess deaths if it's preventable and treatable, we know that there's only a very small proportion of people, I forget exactly what it was, I think it's maybe 40%, maybe under 40% of people who get all their 8 care processes at the moment. So one of the purposes of the Tackling Diabetes Together programme is to not just to reduce to halt the increase in prevalence, but also to improve the outcomes of people with diabetes. So one of the things we want to do is to improve self-care. So we heard yesterday about the NHS Wales app. So we're looking at whether we can get the data into there so that people can see when they're supposed to go for their tests, what their own numbers are, so that they can take better control. They know what they need to do when. We can also, I hope, help to use that data to help us do the monitoring and evaluation of those interventions that we're doing through the Tackling Diabetes Together programme, so that we have both the primary use for the data and the secondary use of the data. And then I think there's other things that we could get into that I would really like to be able to do, like personalised risk. So a GP could sit there and see who were at the highest risk and could focus on those people first, that kind of thing, building that kind of thing in. So there are some really exciting things, some really good opportunities that we have from what we've identified, starting just with that very simple dashboard, looking at excess deaths, going through that deep dive, doing the projection, mobilising the system behind, let's focus on diabetes. And then there's some more things that we can do across the system. So, yes, those things. So the question is, we've done that simple bit, and that's great. And then I've talked in the future about, oh, we can do all these other things. These would be really good. It's not like they're new ideas particularly. So the question for me is, why are we not doing more of that cool stuff? Yeah, I had a better slide than this. Should have sent the right slide, sorry. But this will do. So why aren't we doing the right stuff? So I want to start with data quality. So we start off, everything is based on data quality. We struggle sometimes with the data quality. We know that clinicians are really busy. It takes a long time to do the coding. How can we really understand what's happening in the system and the pressures on the NHS if we don't really know what's happening? So there's something about making sure that we get that value back to the people who have to do the coding. And there's another really, again, really exciting opportunity here. How can we use things like ambient voice technology to help with that coding, to take the pressure off? And I think this is somewhere where actually the technology really can help. It doesn't have to be 100% right all the time, but even if you get it to do 50% of the easy stuff, that still halves what people have to do. So there's some really exciting stuff in that. It's an important point about capability. In the NHS, we don't have professions for digital data and analytical staff. So currently there's no competency framework, there's no learning and development framework. We tend to use fairly outdated job descriptions, so when we're recruiting, what we're asking for isn't recognised by people outside, and we don't bring people in. And I think that probably means we're slightly behind in what our potential is amongst our analysts, digital and data scientists. And part of that is about being able to tell that story. It's easier to tell the story when you've got the right slides, but I've got through it somehow. Maybe that's something I should learn as well, about telling that story. So I talked at the beginning about dashboards. So we have lots of dashboards, we have lots of information about diabetes, but actually the thing that made the change, the thing that was the catalyst for change, was pulling out that one thing and saying, look, this is the thing that's happening. Not leaving people to fight through loads of dashboards to try and work that out for themselves. So an analyst is not someone who just is a data manager moving data about, but is able to tell that story and use it to affect change. And this comes back to understanding the value. I think it's all built on that data quality and data collection. We know that clinicians come to us in Public Health Wales and go, we want to see cardiovascular disease by small areas, which is difficult, or it's impossible. But actually then we can go back to them and say, well, you can have that, but what you need to do is to make sure that that somehow you're doing the coding gets done so that we have the data so that we can do that. We need to close that loop so that people can see what's happening. Data access, well, we've talked a bit about that. I think there's a cultural aspect to that as well. It is difficult when we have Wales, it's not that big, but sharing data even between health boards and Public Health Wales can be difficult sometimes. Yeah, we've talked quite a bit about that before. And then I want to end with technology. So my dream would be, what we really want here is, as I said right back at the beginning, to have the right data in front of the right people at the right time. We have a huge opportunity here. You heard a bit about the National Data Resource in Wales yesterday, and also quite inspirational about the French version of that as well, which is already up and running. This is a big opportunity for us. We still have the cultural and data access, legal data access issues, but if we can automate some of those data flows, automate some of that reporting, we won't have to go to, well, I don't want to overstate it, but we won't have to go to Emma and spend 4 years putting data together. Hopefully we can automate it, we can see what's happening, I don't know, maybe every month we can look at outcomes, we can react more quickly. We're not waiting, we're not looking at 2021 data in 2025. And I think that's a huge opportunity for us. I'm very excited about what we can do with that. It also gives us the opportunity to do more big number crunching. Some of this data linking, you can't do it on a laptop. So I am quite excited about the NDR. So I think, and we're doing some work around capability as well, I think the things that are stopping us, we have some parts of work that are helping to take us forward, but there is, as ever, much has been done and there's much more to do. And hope, yeah.
Thank you. Thank you for setting the ground. Mike, you want to address from the lectern also, or you have a presentation, or you...
Good morning, everyone. So I'm from the Life Sciences Hub in Wales. I'm head of program management. Yesterday you heard from Rodri in the fireside chat about some of the work we're doing at the Hub, and today I'd like to expand on that and share how we are trying to address AI into the NHS. So firstly, here's a little bit about who we actually are. So we're an arm's length body of Welsh Government. We're an independent body, and we work as a team to try and act as a front door to industry, but also work with public sector to drive solutions and innovation on behalf of the patient. So if you can see here, we have three key drivers. I mean, firstly, to improve and enhance patient care and experience. And we look at that every day. That is what we are passionate about. Drive productivity for the clinician. So how do we do more for less? How do we improve systems? How do we drive value and remove waste? And lastly, we're also co-funded by the Department of the Economy. So we also look at how life science in Wales can be driven forward and grown, basically. And I call those our system needs. Now, if you look at this from two perspectives, firstly, we are the front door to life sciences in Wales. That means we get a large number of inquiries from innovators, CEOs, passionate people who want to drive their solutions forward and come to us. And I call that kind of push. So that is them pushing on our front door and looking for help. The other perspective is for us to identify through patient need what direction we need to take from an innovation aspect to be able to draw the right innovations into our healthcare systems. And really, there's that tension there. And what we've heard over the last couple of days with respect to AI in particular is what are the opportunities, but also what are the pitfalls we need to try and avoid, or at least get our arms around in terms of governance, in terms of infrastructure, in terms of big data, in terms of how do we move forward together on behalf of the patient with pace, but also with control. So let me start with the front door piece. So I'm not expecting you to take all of this in, but essentially how we act is every year we get about 400 different innovators knocking on our door, looking for help. And every year, I would say, and growing, we get about 100 different inquiries from AI and digital-based innovators looking for support. Our job's to try and find them the right door or to champion their needs directly. But each one of their innovations is going to be very different. And whilst they're passionate and there may be a solution that supports the whole of Wales, it may also not be that solution. And therefore we have to be objective and we have to work out, firstly, what do they want and how do we refer them to the right place and champion on their behalf. And there will be golden nuggets in there that we want to be able to grab. We want to be able to accelerate their journey, their path into public health. So our job there is to connect and convene, to integrate, to accelerate, to advocate on their behalf. And it may be something like an app or some piece of software. It could be something bigger than that. It could be a whole solution to a pathway. But each one will be different. And if you think about all the aspects of what we've seen over the last couple of days, all of those things have to be considered. So what about the pull pathway? This is where we're really starting to redefine how we operate with respect to some of these big challenges. So here, this is a co-production, by the way. This is not our work in particular. We've worked with Scotland, we've worked with Norway, we've worked with a lot of other nations to gain exemplars as to how do you drive needs-based solutions into public sector health. So if you look at this in a bit more detail, and if you take, for example, the leading cause of death in Wales currently is cancer. If you break that down, it's a whole huge number of diseases and a huge number of pathways. But if we understand those pathways in more detail, and try and prioritize in terms of need, then you can start to work out, well, okay, how do we truly understand what the problems are and how do we drive the right solutions? And we can't do it alone. It takes all of us. It takes a village to raise these children. And so many people here and many people who have been present throughout the 2 days are involved in some of this work. But essentially it starts with the patient pathway. So if you took lung cancer as an example, what is the patient pathway for lung cancer in Wales today? What's that value stream look like? Where are the gaps? Where are the obstacles? Where are the pain points? How do we understand that more effectively to drive change? And to drive change in that controlled manner. So we do technology and horizon scans. We've got a superb sector intel team, and they will put together reports that identify, well, what's out there? What's happening in Wales currently across those 7 health boards and those 3 trusts, those 2 organisations that are used for advice? How do we get to the stage of where are we today? What's the baseline? And then we've got our partnerships team who will reach out to the strategic clinical networks to get their feedback. So we will go to the networks, we'll drive workshops that say, these are what we are seeing as the pinch points. These are what we are seeing as the options in terms of solution. Give us your feedback. What are you feeling at the front line? What are your patients feeling? And how do we try and connect the dots? So with that clinical feedback, we then try to confirm priorities, and then we deep dive into the technologies. And this is where it could be precision medicine, very much AI. AI is across all of these opportunities and all of these solutions. And then you ask those key questions that we've all been asking this week in terms of systems readiness. Are our hospitals ready to receive these solutions? If not, what needs to be done at a higher level and a broader level to try and address that? There's no point trying to take a solution that may be ready, but our infrastructure isn't. Similar with data, similar with documentation, to be able to drive things forward, it's not just a single data point, a single solution, it has to fit. So our role there is to try and work out, okay, what are the system requirements? What's the appreciation around procurement standards as well? So maybe this is already in flight. So we have to collaborate, we have to communicate, we have to understand what else is going on. Due diligence, company credibility, is this adoption ready? What are the industry inputs and reviews that are out there, and what can we learn? What evidence base is there elsewhere on the globe? So are there other areas where actually this has already been done? So why are we reinventing the wheel here? How can we learn from that and drive this forward? So all of those aspects lead us to a funnel of solutions, and then we look at how do we build those project proposals. So it doesn't stop at that desktop exercise. It's then about, well, okay, what's the next step? How do we get this to where it needs to be in an environment where there's already tensions, there's already pressure on systems, there's already things that are taking up everybody's days. So we have to somehow find those projects, those programs, the resources, the funding, everything that's needed to drive that innovation forward. And of course, we're a nation. So there's 3.1 million people here, and everyone deserves that right to a solution. So you might start small, but you've also got to consider size and scale and adoption across the whole nation. So all of those aspects have to come into being. And I would say we're building this plane as we're moving through. So, you know, we've got a program of work. It covers the Tackling Cancer program, which is a coalition of the willing and mandate through Welsh Government to drive solutions to cancer in particular. But as we work through this program, you know, there's some fantastic opportunities to really drive solutions on behalf of the patient, but it can't be done in isolation. It has to be done collectively. And so these are what I believe are the key considerations that we have to look at. We have to consider to get this working well. So firstly, patient first. I think it was mentioned by Helen on day one, do no harm. So this has to drive benefit. It has to be better than where we are, either in terms of pace, in terms of accuracy, in terms of diagnosis, in terms of time frame between referral to treatment, all of those aspects, or, ultimately getting back to wellness at the end of the day. It takes a village, so collaborate, communicate. We work with all the health boards, we work with many organisations, and as a devolved nation, there are 60 or more different organisations involved in all aspects of healthcare. So it's, back to that referral piece on the second slide, where do you take the solution to get the best outcomes? So it takes a village. Collaborate, communicate more. Identify the key stakeholders. So how do we drive this forward in the right manner with the right inputs and the right outputs? Funding. This one's huge. You can get the best projects to a really good stage of business case, opportunity, but unless you've got the money to do it, it sits on the shelf. So really it's about how do you ensure those projects can get executed on? How do you prioritize the right ones that are going to make the biggest difference and get them in to the right healthcare system such that they will work? So knock on every door and knock again. Okay. Work with experts, both from a user and a supplier standpoint. So our job as a life sciences hub is to be the glue between the need and the supply. So where that supply comes from is we need to be as in bed with those guys in industry as we are with those in the wards. So to be able to make this happen, how do you carry that baton from one end to the other? Okay, understand the data path. What's changed? Are there any risks? That's been discussed ad nauseum the last couple of days, and rightly so. Understand the pitfalls of going too big, too quickly. Build a path. We talked about pilotitis yesterday, but actually a good pilot tells us so much, but it's ensuring that it doesn't stop there. That once we've built that pilot, we understand how do you then size and scale. Information governance is complex. We also heard about that yesterday. So actually use the experts, right? Ensure that we are maintaining the right pathway to get things done quickly and compliantly. Procurement. And then lastly, appreciate the change curve and be that change agent. We need passionate people, but we also need objectivity to be able to drive things forward, and impartiality to make sure we are choosing the right solution, not just the one that shouts the loudest or knocks the loudest on the door. So lots going on, certainly in the area of AI, but what I would say is it doesn't start with AI. That's part of the solution, not the problem. Understand the need, define the problem well, and explore what is the right solution to get you there. Thank you.
As we have Elena Petelos cannot join us, and fortunately David offered to share some reflections. So we are now going into closer to reality, and a case study from an interesting center of excellence. Go ahead, David.
Testing. Oh. So the request from Paul was to look at an area where, based on our reflections from the last couple of days and what we've been hearing from you all, where we feel that the secondary use of data is, I think, and you'll excuse the pun as you'll find in a minute, it is going to run into a sort of brick wall in terms of some transformation of the NHS, which has some very defined deadlines. New hospital programme in England. So this, a little bit of context for everyone, just in case you haven't come across it. So this was the announcement a few years ago by Boris Johnson that we were going to throw up 1,000 hospitals in about 3 weeks. Obviously that didn't happen. However, over time, it has evolved into a program that is now very much in flight. Back in January of this year, there was a final sign-off of the first wave of that program, so the set of new hospitals for England broken into 3 phases, 3 waves over 15 years, with 16 new hospitals in the current 5-year period. Highlight a couple of groupings within that. So you have 7 what's called the RAC hospitals, that is reinforced aerated autoclaved concrete. You may have heard it in the context of schools in the UK. So this is the concrete that's literally falling off the buildings. The hospitals in these cases are falling down around them. So 7 of those 16 have been prioritised because the current hospital site is built of that RAC material, and they will not be safe to occupy pretty soon. So they've got to do something about those top 7. The RAC sites. In that wave 1, there are also a further 9 non-RAC hospitals, so those are prioritised into that first wave for other reasons. In terms then of Atos's engagement, actually I'll just jump back a second. In terms of Atos's engagement, we started work with NHS England back in 2020, 2021. And produced a document titled as the Blueprint for Digitally Advanced Hospitals. I'm afraid you'll hear me voice my frustration several times in the next few minutes. The fact that we keep referring to it as hospitals. There's a huge amount in there which is actually about the digitization of the health system and how the new hospital fits in the context of that, because actually, of course, what you're building here needs to be based on demand and capacity modelling that assumes a lot of movement out of the hospital setting into community, into social care. However, because it's a new hospital program, all the titles at the top say hospital. So as I say, I'll get frustrated about that a couple of times during the presentation. So that Blueprint for Digitally Advanced Hospitals was a consideration about what technologies and data were in prevalent use in healthcare globally at that point. And also a forward look of 2 years, 3 years, 5 years, 10 years, what Atos perceived as the technology and data infrastructure that would support health and social care over that time period. Now, we're 5 years into that now, and I suppose the good news is it doesn't look like we got it too far wrong. The Centre of Excellence then. So this is actually a relatively recent creation. It's an industry-led partnership that's been formed with Atos and 3 other large global digitals. I can't name them yet, unfortunately. We're actually not having our public launch until November, so this is a bit of an early tease. And supporting with that an ecosystem currently of about 40 to 50 small and medium enterprise across a range of technologies, which I'll touch on in a second. A set of NHS Trailblazer organisations, so these are the organisations who are feeding us the exam questions that they want answered. Again, I'll touch on that in a second, as well as starting to bring in academic partners now to bring some rigour to the assessment of how these technologies will genuinely achieve outcomes and transformation to future operating models for the health system. And therefore, whether those new hospitals, when they open, will actually work from day one, whether the demand and capacity modelling, everything we're doing for the secondary assessment of data at the moment, has resulted in a hospital that's the right size and has the right configuration and the right rooms. So I mentioned earlier that blueprint for digitally advanced hospitals. This is the result 5 years later. The list of 49 intelligent hospital capabilities. Back to my usual frustration, why are we calling it hospital? But anyway, so these are, or intelligent indeed. Now these technologies are effectively mandated as part of the business case for these new hospital sites. So that those 7 RAC hospitals that I mentioned earlier, Atos is supporting 2 of those at the moment, who are the sort of chronologically the first in the scheme. To produce the business case that will go forward to Treasury early next year. For the build of the new hospitals, we take one example, a total scheme size for that new hospital of about 1.5 billion, with about 9.5% of that being on the digital and data elements of the scheme. The digital data elements being categorised as these 49 technologies. 3 categories, and I'll let you read the list in the background, and I think the slides are going out afterwards, but 3 categories. So we've got the purple ones, the fabric. So that is the physical stuff behind the walls, absolutely. However, and most critically, I think for our interest in the room, also the introduction of significant additional data sources in that new hospital setting, bringing new data to our availability that's not been there before, the IoT data, the smart building data, the technologies in the rooms which will do falls monitoring. Wonderful stuff, useful core stuff. However, we're probably more interested in the pink and the light blue. So footprint technologies are more about the interaction, and again, this is where I get frustrated about them calling it the hospital capabilities. This is actually about how that new hospital embeds in its broader health ecosystem. So this is about remote monitoring, digital front door. How do we make sure that we have cohesive end-to-end pathways going out into community? How do we do step-up control of patients to avoid the patient coming into the ED in the first place? Digital therapeutics, treatment in the home, those sorts of technologies. We then touch on the flow technologies, and these are probably more introspective to the hospital building itself. So this is more about once the patient's in your hospital, how do you manage the end-to-end flow of in, treated, out the door? I think a fascinating program from our perspective, and the reason we created that Centre of Excellence with industry. This is really quite experimental, and it's quite experimental when you have a really hard deadline. You know, these buildings go up and open to patients in 2029, 2030. If we get this wrong, if we haven't achieved the new operating models that these technologies deliver, those hospitals will not work on day one and will have corridor care, which just cannot happen. There's nowhere globally that's done all of this together. Each of these technologies at a sufficient maturity level has to be done somewhere globally, otherwise it can't be on the list. That was a category for us creating this list originally. But there is no one place where you can see all of these technologies and the data they consume and the data they create working in concert. If you want to go and see really good patient flow, you can go over to Oslo, you can see what they're doing over there, absolutely fantastic work in a sort of cluster of these technologies over here. If you want to go and see command and control of a hospital in the context of its regional health system, go to Humber River over in Canada. But there is nowhere that's doing it all together. Equally, the level of outcome needed from the implementation of these technologies is significant in the context of those new hospital buildings. The new hospital physical design, this hospital 2.0 concept up at the top there, so that physical design and how big you build this hospital and what layouts you have and what your rooms look like is predicated on all of these technologies being present and the new ways of working that they engender being fully adopted and embedded well before you go into that new hospital building. So it's a big experimental challenge for us to bring this all together and see if it works. For a lot of technologies, and as I said, a lot of industry partners and small and medium enterprise having to work in concert for the first time. Last, I think, reflection on this, I suppose it's what's missing from the data perspective. So 49 technologies. Each of these trusts I talk to their CIO, CFO. They definitely do not want to run 49 procurements and 49 technologies and figure out how all those are going to be plugged together themselves. What's also missing from here is the data layer that sits over the top. We do not want 49 siloed data sets that we might be able to integrate through all the stuff we've done before. It's going to be impossible to bring the outcomes from this without figuring out how some of these data sets come together from a data architecture perspective before we do the implementation. Recognizing as well that some of these data sets are novel, certainly in combination. So have we really, anywhere globally, integrated a smart building data set into a clinical operational flow data set? We might need to here because we're going to be powering down, up and down our operating theatres dependent on what our lists show. Smart city data sets, that's very much part of this. Actually, can we predict our flow through the emergency department and influence our staffing levels hour to hour based on smart city data sets about the fact the buses are running late or that there's been a big car accident on the motorway up the road? These are all things that are assumed to be possible in the physical design and operating model. I would also, I think another interesting one for me, and perhaps last point before I wash up, we were having a discussion on one of the tables yesterday about the fact that secondary use of our clinical data is obviously absolutely key to getting this design right. We need to understand at a macro scale and over a longer term scale how our operational data feeds the design and the scale of these new hospitals. What we're seeing as part of the implementation of this and the sort of early experimental work is it's starting to become much more immediate and timely. So it goes from secondary use of data as research, which we have time to look at over a longer period and use to define the design of the new hospital, to actually the secondary use of data is going to be used to plan tomorrow's shift. It's going to be used minute to minute, hour to hour, and day to day, not month to month and year to year. And the example I gave on the table yesterday, one of the digital leaders who are working with one of those hospitals has a fantastic example of McDonald's. So she used to be a site manager for McDonald's a few years ago, and every morning the site managers get an email saying, well, based on this predictive analytics we've done, you're going to get 20% extra footfall than you would have expected yesterday. And that's because there's a football match up the road. And last year we had a peak on this day because this, and this was happening. Where's that in the NHS? If you're actually your operational manager, where's your flow data that's not just at the macro scale, do we do this week to week and month to month, but Tuesday the 5th of November, we've got a problem because. And again, that sort of immediacy of secondary use of data is something that within the context of the new hospital program moves from something that we know we should be doing and so on, but actually becomes mandatory because those emergency departments aren't going to be built big enough to not have that level of insight driving them. And I'll just close off because give Paul some time back, hopefully. So in terms of that Centre of Excellence offer, we are working with several of those new hospital sites at the moment. That industry consortium will be providing a laboratory environment, test the technology, extract the data, see what we can do with it. Physical and virtual demonstration. Strangely enough, the clinicians don't actually believe any of this stuff's real. So in doing the business cases, we sit there saying, oh, the ambient listening is going to record your conversation in your multidisciplinary team. You're never going to have to type anything up. And they go, oh, yeah, right, cool. So we need to do some work to persuade everyone that this is plausible. And then actually a key one is, and it's been mentioned already, is funding. So yes, the new hospital program comes with a nice lump of capital, which will fund the digital transformation of those systems. But actually the digital, it's not going to be enough. So looking at other novel ways that we can, between industry and the NHS, drive alternate sources of funding to get this transformation delivered. Thank you.
Thank you so much, David. Okay, so last in the line is, last but not least, Iñaki Gutiérrez-Ibarluzea. That is probably the worst pronunciation that I've made of his name.
But you are trying. And that is important. So it's trial and error.
But Iñaki is going to close the lightning talk, and I have a proposition for all of you because we have to make the most of this morning productive for all. So I propose that we convert a World Café in a World Café with Café. That means that you are going to sit in tables for the discussions, and I will be your waiter. I will take notes of what you want, and I'll bring the coffees to your tables. Would that be okay? Fantastic. Would that be good deal? So Iñaki, over to you.
Impressive. I think it is good morning in Welsh is Boreda. So Boreda, Egunon, buenos días, good morning. This was to show that, and I think it is tremendously relevant, the talk this morning from Tiago. I've been extensively working in health technology assessment for the last 25 years. And what it was described by Tiago this morning, it is what we have been suffering, informing decision making. Nowadays I have the other hat, So I'm the one that is receiving the information to make the decision. So it is also challenging because those are things that are the way that finally the things occur. Another thing that I wanted to say is I could have talked about what are the things that we are doing with trying to deal with data in terms of secondary use, but I wanted to make you feel discomfort in your seats. So first of all, I'm describing this because I still remember that my first meeting when I started working in health technology assessment, a manager told us, I wanted you, those that are providing me with information and evidence, as the drunk people to street lamps. It is to give me light, not to give me support. And I think it is important because most of the things that most of the decisions that we are taking in healthcare systems are based almost on nothing. And there are so many uncertainties, as it was described this morning by Tiago, because most of the things that we are introducing in our systems, any kind of technology, drugs, medical devices, and other type of tools, what we are using to make decisions are theoretical value. And in reality, we are obtaining much less. And this is one of the reasons by which, as we understood yesterday, and there are so many papers, there is, I would say, 20 to 30% of waste in the healthcare systems. And we as public officials, we should try to avoid that. The other thing, it is, I'm putting this cartoonist for two reasons. First of all, because I love him, but the second reason is that he's supporting my football team. So he's supporting Athletic Bilbao. For those that are not very keen in Spanish, there is a translation in the bottom. So one of the things that is important, it is what are we talking about in the healthcare systems? And when I studied quality, there are three things that are taken into account in systems: processes, structure, and outcomes. And what are we talking about in healthcare systems? Waiting list, average length of stays, lack of professionals, generational change, professional vocation, access to innovation. What is missing? What is missing? So we are talking in most of the cases about processes and structure, but we are not talking about what is important. There are outcomes, and outcomes from the perspective of professionals and from the perspective of patients, that are the clients. And if we are talking about health systems and not healthcare systems, we are missing the citizens. Nowadays, we are talking about real-world data. We are starting talking about proms, prems, and chroms. We are starting because for many years, we have been talking about processes, data flows, and patient flows, and not about what is important to those ones that we are intended to take care. The other one, it is the finite budget. I don't know how many times I've heard we don't have more money. We don't have more money. For those that are not very keen in Spanish, once again, there is in the bottom, there is some kind of translation. So, budget. We learned when it was the pandemic, we learned that I don't know how much it was spent in the case of Wales, but in our case in the Basque Country, we spent 1 million more each day of the pandemic. 1 million euros more. So that supposed that we had a deficit in the budget in 2020 of 300 million euros. But no one took care of that because it was important. We should move economy. We should be out of the lockdown, and there was a reason. So anyone put any kind of effort in terms of making things different. So budget was not that important. But once again, being public officials, we still have some kind of mandate in terms of doing things different. my question is, what was first, the answer or the question? We are talking these days about technology. But technology, it is the answer. It is not the question. So we are putting first the elephant in the room without thinking about why the elephant is in the room. And I think it is tremendously relevant. So we forget the question or questions, and we focus on the answers or the technology. I've heard so many times, well, what about introducing this new medical device in the hospital, and which the consequences would be? And it's the contrary. Why do we need that medical device? And what are the outcomes and the value that we will obtain with that investment? And I think it is also tremendously relevant. So I'm not advocating with wine, although we are a region that we are wine producers, but it's true, wine is not the answer, but you forget the question. So I think also it's tremendously relevant. What we have learned, I was shocked with the last I would say report that was written by I would say very clever people, Imperial College. So they put the future state of health and healthcare in 2035. There was a report from Lord Darcy saying we are almost bankrupt. There are big issues in the NHS right now, and we need to solve them. But I was shocked when I heard the future of the NHS is focused on becoming a more digital, preventative and community-focused healthcare system with a greater emphasis on personalized care and the use of technology to improve efficiency and outcomes. But when we go in depth, he put key strategies include leveraging artificial intelligence and genomics, integrating care across diverse settings and providing patients with tools and information to manage their health. Nothing about what is the value that we are going to provide to our citizens, and which the problems that we have right now in reality in health. And if you go in detail to the report, it put integrated data to deliver impact, the digital front door. Well, it was something related to health. It was the obesity breakthrough. And then the wearable revolution, the genetic gateway, AI to drive patient power and productivity, and robotics to support precision. Everything is around technology, nothing around health, nothing around which our problems are and how those technologies could mediate in improving the health status of our population, and nothing about public health. I was very I would say I was very shocked with the talks this morning, and I'm very followed because I'm also a public health advocate and clinical epidemiologist. So that is also important on my side. So we have learned almost nothing. Data. I was used to use this quote. So it is from Edward Deming, a sociologist, and he was one of the persons that moved Japan in terms of improving during the 60s and 70s. And he was saying, without data, you are just a person with an opinion. And it is more or less what we have done in the last years in terms of planning in most of the healthcare systems. But I found this other quote more recently, that is, without an opinion, you are just a person with data. And I think it is tremendously relevant. If you don't have, and if you don't make the correct questions, it is hard to take the best answers. So I think we are nowadays in the data revolution, but still we are lacking the correct questions. Yesterday I learned the concept of AI, and not just of IA. And there is a famous Mexican song that is ay, 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 ay. So it is, I don't know. So I think AI, I'm advocating in favor of AI, but we need to have the correct questions for AI. Otherwise, we will finish with ay, ay, ay. In the most accurate world, I don't know if you know this guy, Adrian Newey. Adriano is one of the top engineers in Formula One. Nowadays, I think he's the one that has changed the Formula One concept, because he was not having the best engine, but he has the best car. That is the most important thing. Because he was fitting the car to the needs of Formula One. And nowadays and recently, he has moved from Red Bull to Aston Martin. I'm following because I was following Fernando, so that is the Spanish driver, not from my region, unfortunately, but still important. And he was saying, it's fair to say that independently that we have very accurate data because of the sensors that we have in the car, I cannot provide a good car for 2025 for Aston Martin. We need other type of questions, and I don't have the sensors located in the place that are needed in terms of making a good car in 2025. So independently that I could have the best data, if they are not located in the areas in which I need, they are useless. They are useless. So all that science is not gold. And what about AI? And we need to be very careful. I found this, that a study shows AI can decrease clinical skills. And it was written recently. You can find I think the quote and the reference there. And it was written in I would say, a very prestigious journal, that is Lancet. What is more, when you went in depth to the study, those that started using AI, especially radiologists, were losing the skills that they have. And what about when technology is broken? Same applies with nowadays robotic surgery. Nowadays that we are talking about robotic surgery is the perfection and so on. When we have a problem and we need to do open surgery, the problem is that we don't have trained professionals to do so. And that is a big issue. This is from NICE some years ago about digital health technologies and how they classified. And they were looking at the different levels of risk. And when we are taking decisions, we have intended and unintended consequences of the introduction of a technology. And they put in three levels, tier C, tier B, and tier A. And it was related to the risk. Similarly, we have done in the European Union about the classification of digital technologies, including AI solutions, in terms of risk. And we classify class 1, class 2, and class 3. And AI solutions based on risk, if they are just, and I'm reinforcing this, just informative, but information is changing your mind. So we need to be conscious. The second one, it is decision support systems. So still you have the right to decide, or those that are doing independently, without any control by humans. And that is the risk thing. Once again, I'm not against technology. I'm very in favor of technology, and they are going to solve most of the problems that we have. The other thing is how we are measuring and how we are prioritizing, and this is also removing from my seat, and it's keeping me not sleepy at night, or not sleeping very well. When we are talking about how we are making decisions on the basis of the tools that we are obtaining, probably you have heard that we are using cost effectiveness, we are using things like QALYs, things like DALYs. But in most occasions, once again, what we are promoting are things that are related to healthcare and not to health. There are new tools that are proposed in terms of also put at the highest level public health interventions, like PALYs. This is new ways of measuring the value, PALYs. So this PALY is related to something that probably would be of interest to companies, because that is related to productivity. And I think it is pretty relevant, because they put how much we lose as a society for someone that has a pathology. And I think it is tremendously relevant because we are losing someone that is doing things that could be helpful for the society as a whole. And we are not talking about just pathologies, but being healthy or not healthy. And I'm finishing with this. Life is what happens between meetings and forums. So the old hymn for eskerrik asko. Thank you very much.
Thank you. Thank you so much, Iñaki. No, you can keep it because we're going to now do the World Café with Café and Waiters. So let's see if we can get lightning talk speakers. Please go to a table. Pick one table. We'll start from there, as I will then be sharing with you the document that we are using for the joint charter, so you can have the notes from your discussions. Pick one table, okay. So, David, maybe if you could pick this table, or this table here with three gentlemen, and Emma here. Yes, Matthew, and the other summit participant, whose name I don't know yet. Could John here too. Any table? Yes, let's make the table starting. Okay, we have 10 minutes. I will be by your table to order the coffees. 10 minutes we have until 11.